Thank you for joining us tonight for the National Spine and Pain Center's Clinical Development Series. Tonight we are talking about NSPC Fellowship with our moderator, Dr. Peter Stotz. We're going to allow everyone just a couple of moments to get logged in, and while you're joining us, we'll go ahead and show you our educational material. You can go on to the next slide. This is the educational material for this evening, including our learning objectives and how to claim your credit. We will repeat this information at the end of the program. We will also include it in the chat box. You can go to the next slide, please. This is the disclosure information for our full faculty this evening. This will be repeated before each presentation, and we will begin the program in just one moment with our moderator, Dr. Peter Stotz. Thank you all for joining us. We will now begin the program with our moderator, Dr. Peter Stotz.
Well, good evening, everybody, and very happy New Year. I'm excited to have the next in our series of the NSPC Clinical Development Series. And tonight's a special night for a lot of reasons. First of all, it's the beginning of the year. It's a refreshing opportunity to learn something new. But we've also got our first ever invited speaker joining us tonight, Dr. Andrea Truscott. And we also, of course, have Dr. Mayo Friedlis, who many of you know. We're going to have Dr. Vallejo have a returning event for us tonight to talk about clinical research. And of course, Dr. Terry and Sejan, who's going to talk to us about our own NSPC fellowship. As normal, we're going to do this in a little rapid fire session, so no one dives too deeply into any one topic. And as I was thinking about the issues involved that we really wanted to come up to speed on, what we've covered to date, a glaring hole was opioids. And what do we do about opioids? It's kind of in some ways, it's something that all we talk about is opioids. In other ways, it's not something that is the focus of many of our practices. I was fortunate. I've known Dr. Truscott for close to 30 years. I think she was 7 at the time when we met. We've been friends for many, many years. And I was fortunate to sit on a panel with her recently at the Health and Human Services Task Force, where she was, I think, the representative of ACIP, if not an overall representative, on the issues of opioids and how Health and Human Services should be approaching patients with opioids. The original problem that we all saw was after the CDC guidelines came out, many physicians just all of a sudden stopped prescribing. They were afraid of them. Meanwhile, there are many physicians out there who are prescribing with a sense of impunity. And so having a balanced approach was what the Health and Human Services Task Force was about. I've seen Dr. Truscott's presentation in the past, and I've asked her to kind of give us talk about what's the myths out there, what's the balanced approach for this, and what should we be thinking about with our patients with opioids. So without much further ado, Dr. Andrea Truscott, past president of ACIP and certain 1,000 other organizations, also CMO over at StimWave, which I don't think is got any CME implications. This is not what that day job is not around opioids. Dr. Truscott is a world expert in this topic, and I'm going to turn it over to you to discuss opioid myths. Dr. Truscott.
Well, bless your heart, Peter. I really appreciate that. So, whoops, that didn't. We switched out. We need to go back to there. We go. All righty. Let's see if mine will work. It worked when we applied. There we go. And so, as Peter said, I'm a lot of past of a lot of things. I was a professor at the University of Washington and past director of the fellowship programs at the University of Washington and the University of Florida, past chair of the education committee on the World Institute of Pain, and the past president of the American Society of Interventional Pain Physicians. And we don't have, there we go. And so since money can't buy happiness, we'll be switching our assets to mood-altering pharmaceuticals. And I think there were a lot of doctors who moved into that. We've had our biblical plagues of locust frogs and vermin, and now we have our modern plagues of prescription painkillers and heroin. And I love this graphic because it just shows how dramatically and how fast the opioid epidemic started spreading across the United States. As any of you, unless you've been under a rock, you know there's been an opioid crisis, and that whole generation has been in crisis with this. And as physicians writing opioids, we've been considered the point of the pen. We've been considered the cause of the problem. And so why don't we just stop writing opioids? Well, chronic non-opioid pain is a serious comorbidity, and it affects over 95 million people, about 30% of the US population. And though effective non-opioid treatment would be the most desirable, that option doesn't exist for all patients. So we're going to talk about a variety of opioid myths. The first one is that all of you have heard America has 5% of the world's population, but uses 80% of the world's opioids. Well, not quite true. The US only has about 30% of the world's opioid supply, and that actually includes addiction treatments with methadone and buprenorphine. We do use 80% of the world's hydrocodone, but most of the rest of the world has no access to opioids, and that's why most of it is being used in the United States, because we do have access to it. So in 2011, I got a chance to be part of the United Nations Office of Drug Diversion and got a chance to present in Vienna. And we put together a publication ensuring the availability of controlled medications for the relief of pain and preventing diversion and abuse. I had the advantage of being part of this and the acknowledgments there. And what we said was, notwithstanding the universally recognized medical indispensability of narcotic drugs and psychotropic substances, the World Health Organization estimates that every year tens of millions of people suffer disease, moderate to severe pain, and death because they don't have access to controlled medicines. This lack of availability of controlled medicines represents a major global health problem. Myth number 2, 80% of heroin addicts began by abusing prescription opioids. Well, again, not quite true. Only 4 to 6% of people who misuse prescription opioids go on to use heroin, and the number of people who started heroin without taking prescription opioids first has been rising in the last few years. And this was based on a variety of studies. The most recent one was done looking at heroin use among non-prescription opioid users in the club scene. So they looked at people who were using prescription non-medically prescribed opioids. So this would be your Oxycontins and your hydrocodones and all of those, in a group of young people who were in the club scene, and they were using those drugs. And then they too, over the next couple of years, looked to see, followed these people to find out how many of them actually ended up using heroin. And as I said, it ended up only being about 7% of that population. So myth 3, addiction starts with a prescription. Well, again, not quite true. For chronic patients on chronic opioid analgesic therapy, what's been often termed COAT exposure, with no previous or current history of abuse or addiction, the percentage of abuse and addiction was calculated at 0.19%. The incidence of addiction in another study was 0.1% among commercially insured patients who first received an initial opioid prescription and then got a diagnosis of dependence within 2 years of filling that prescription. And so, so where does this opioid abuse come from? Most abused opioids begin with people taking medicines that were not prescribed to them, using pills that were stolen, purchased illegally, or obtained from friends and family members. And so this is from the National Drug Control Strategy Annual Report in 2010. And you see that there was very few, 17%, that came from one doctor, and the vast majority of it was either free from friends or relatives, bought from friends, took to relatives without asking, bought from a drug dealer or from other sources. And people who suffer from chronic pain disorders are no longer being prescribed opioids lightly or quickly. and so it makes addiction a rare outcome. It may be that opioid addiction probably starts with a prescription, but it's usually a prescription for acute pain. And for many, the addiction starts with someone else's prescription, perhaps taken from a family member or obtained from a friend. So chronic pain patients are not opioid addicts any more than a diabetic is an insulin addict. So there's simply not enough chronic pain patients on opioid therapy to account for the number of opioid and heroin addicts. So the American Society of Addiction Medicine estimated in 2016 there were over 2.5 million people addicted to either painkiller, prescription pain relievers, or heroin. Now, at most, there are 1.5 million chronic patients on opioid therapies. So if you said 5% of them, now remember, we have studies showing only 0.1%, but if you said 5% of them developed a substance abuse disorder, that would still be 500,000 people. I mean, where are the other 2 million people coming from these addicts, if they're not coming from opioids? Well, we can show that chronic pain patients didn't cause the opioid epidemic. For most pain patients, opioid medications are part of a larger routine of pain management, and opioids are not craved any more than an athlete craves a vitamin supplement. So the risk of opioid addiction among chronic pain patients is quite low overall, and there are well-established protocols such as the opioid risk tool to screen patients and monitor those whose risk may be higher. For those of you who are not aware of it, this is the opioid risk tool, and you simply check every box that applies, and you get a number, and you end up with a score. And if the score is 0 to 3, they're low risk. If it's 4 to 7, they're high risk, moderate risk, and if they're greater than 8, it's a high risk. Myth number 4, drug overdoses are killing 64,000 people per year. That was a big one that made the news last year, more than car accidents. Well, yes, 64,000 Americans died from drug overdose, but the opioids involved were only about opioids were involved in only about 2/3 of those deaths, and most of those were heroin and illicit fentanyl, cocaine, and methamphetamines. And this is what's so frustrating, because if you die with an opioid in your system, remember that heroin, diacetylmorphine, turns to morphine in your system very quickly. So if you shoot up heroin and die, the medical examiner tests your blood, and lo and behold, you have morphine in it. And so you're said to have died from a prescription drug. So we can actually look at 4 waves of this opioid crisis, very much like we're having with the COVID pandemic. The first wave began in the early 2000s, and that was deaths from opioids like oxycodone, the OxyContin Express. I will tell you that at one point in the early 2000s in South Florida, there were more pain clinics along the street than there were McDonald's. Then we had a crackdown, and in Florida, we had very rigorous laws about about dispensing opioids out of the practice, the need to monitor the prescription drug monitoring plan, the PDMP, the making hydrocodone a Schedule II drug. And so after that crackdown, people flocked to heroin because pills became scarce and expensive. And then you had a third wave with the illicit fentanyl analogs. And these carbifentanyl, the horse fentanyls, have been just really devastating. And I've never quite understood why a drug dealer would want to kill off his clients, but that's what's happening. And now they're having a fourth wave. This is where we have illicit fentanyl and stimulants such as methamphetamine and cocaine now account for the bulk of the overdose deaths. From 2012 to 2019, cocaine increased more than 3-fold, and methamphetamine increased more than 6-fold. Not prescription drugs, though. Myth number 5, reducing opioid prescribing will end the opioid crisis. That's all we have to do, stop prescribing the medicines, and it will all go away. Yeah, okay. Well, the number of opioid scripts have been steadily declining since 2010, but the number of overdoses has risen sharply ever since. I may have to get y'all to do it. It doesn't seem to be liking me right now. We'll try a next. Yeah, if you could, there we go. So here you see the morphine milligram equivalents steadily dropping. Next. And on the bottom line, you see the opioids deaths steadily increasing. So we haven't seen a change in the opioid deaths by decreasing opioid prescribing. Next. Medical cannabis will cure the opioid crisis. We've heard that a lot. And any of y'all have paid any attention, I've got little old ladies coming in asking me whether will marijuana make my pain better? Next. Well, the problem is that it's a recurring myth. There not only does recent data show that medical cannabis isn't helping in states where it's legal, but the underlying assumption of this myth is that chronic pain care is driving the opioid crisis. That's not the case. So even if marijuana was helping, it's not the pain patients who would be using the medical marijuana that are causing the opioid crisis in the first place. Next. So medical cannabis can cure the opioid crisis. That's the big one. And we are hearing over and over again that the VA is now giving medical marijuana cards out like crazy. The problem is, next, that there isn't any evidence that that helps. There have been no decreases in deaths in states where cannabis is legal, and Alaska was one of those states, and we've had a huge increase in our opioid deaths. Next. And in fact, marijuana use impedes pain control following trauma. Next, they looked at people who had car accidents, and about 21% of them were chronic marijuana users. And what they found is the daily opioid consumption was 8.58 among the marijuana users compared to 6.05 among the non-users. Next. And this one was even more interesting. This was last year, where they looked at the outcomes of patients who had major orthopedic surgery at their hospital over between 2015 and 2017. It showed that the cannabis use was associated with higher pain scores and poorer quality of sleep in the early postoperative period in patients undergoing major orthopedic surgery. Next. They may actually be making things worse. Myth 8, banning opioids will fix the opioid crisis. That's all we need to do is just ban it. Next. Prior experience with drug bans like prohibition didn't work very well, did it? Next. You'd have thought we'd have understood that. So we've got January 16th. It was almost 40 years ago that we had the prohibition. Soon there'll be nothing but the lake to drink. Next. So they started pouring out all the alcohol. Next. And what happened? People started protesting. We want beer. Next. And you started having prescriptions for medical alcohol. Does that sound familiar? For the medical cannabis, we know how this was prescriptions for medical alcohol. Next. And what we also saw was deaths and disability from all the adulterates that were in the illegal alcohols, very much like what we're seeing with fentanyl in the heroin now. Next. So prohibition made alcohol illegal, but drinking actually increased. So I don't think getting rid of opioids is going to be a good thing. Next. Myth 9, there are a lot of non-opioid ways to treat chronic pain. Next. Well, there are lots of them. NSAIDs and physical therapy and spinal cord stimulators, mindfulness. Chronic pain is so horrible that all effective options, including opioids, should be available. Next. And when we look at the Cochrane review for the interventions for reduction of prescribed opioid use in chronic non-cancer pain in 2017, next, what they found was that there was no evidence for the efficacy or safety of methods for reducing prescribed opioid use in chronic pain. Next. Myth 10, opioids are ineffective for chronic pain. Well, turns out there are actually multiple high-quality studies showing that opioids can be effective at least in some kinds of pain. They're not for all patients, and they should be used in combination with other adjuvant therapies. Next. So this is looking at long-term opioid use in non-cancer pain. Next. And myth 11, pain patients are driving the opioid epidemic. And this is the big one. Next. This is the thing that is causing pain patients to commit suicide when they're being unilaterally withdrawn from their opioids without adequate pain relief. So from data published by the CDC, we know that opioids are prescribed 3 to 6 times more often among seniors over 62 than they are to use under age 19. But overdose-related mortality in the youth is 3 to 6 times higher than in seniors. So mortality has been stable for the last 17 years in seniors while it's skyrocketed in youth. Next. And this is a very compelling set of charts. And Red Lawhorn, who is the medical director for the Association for the Treatment of Intractable Pain, put these together from the CDC's own data. And so here you see those patients who are over 65 way outnumber the number of opioid prescriptions per 100 population per age group. So over on the left, you see the young people, and on the right, you see the elderly. So the elderly, hands down, many, many, many more opioid prescriptions. Next. And now you see the age-related adjusted opioid overdose. So at the bottom, that very bottom line you see, that's absolutely straight, is the deaths, age-related, age-adjusted opioid overdoses for the over 65 population. But at the top, the green and the purple, the green are the 15 to 24-year-olds, and the purple is the 25 to 35-year-olds. And so you can see that that is where the opioid deaths have happened, not in the people who are the chronic pain patients who are over 65. Next. And then the last one, which I really like, this is looking at the relationship between deaths and number of prescriptions or MME, the dose. And you can see it's just an absolute scattergram, that the number of prescriptions that have been written, the number of opioids that a patient is taking that's been prescribed has nothing to do with the deaths. Next. So restricting opioids is not slowing the opioid epidemic, and the increased availability of naloxone and improved care by first responders is helping to reduce fatalities, but opioid addiction still needs treatment, and at present, there's not enough of it. Now, I am a board-certified addictionologist, and I would encourage any of y'all who are taking care of pain patients to recognize the addiction. But to be clear, chronic pain patients and opioid addicts are two distinct groups, both of which deserve care and support. Treating pain patients as addicts can lead to denial of care, which can actually increase the number of opioid addicts. And conflating chronic pain with opioid addiction may be delaying care for people who are struggling to find addiction treatment. Next. So I love this from William Barrows. Narcotics have been systematically scapegoated and demonized. The idea that anyone can use drugs and escape a horrible fate is an anathema to these idiots. I predict that in the near future, right-wingers will use drug hysteria as a pretext to set up an international police apparatus. What's interesting is he wrote this in the 1940s. And unfortunately, it's just as true today. Next. So we do have this balance. We've got the Office of Diversion Control, and no, ma'am, we at the DEA do not have a sense of humor that we're aware of. So we have that force. Next. We have opioid phobia versus having a prudent caution. This was a real sign on a family practice clinic in Alaska. And on the right, you see S&P Medical was a clinic here in Jacksonville run by a physician's assistant. She would see patients 10 at a time. You would come in, get a number, standing room only. She would call in 10 people and say, what do we give you? 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 And these prescriptions were written by this retired pathologist who, before the clinic opened, had never written a controlled substance in his medical career. And from the 4 months that this clinic was open, wrote had more than 2,200 prescriptions, unique patients getting prescriptions under his name. He is now in jail. Next, as is the physician's assistant. So there's got to be a balance between pain relief and prescription opioid abuse. Next. And so I believe very strongly, next, in a concept that has to do with one of the fundamental principles of biosafety, the adherence to the practice, next, of universal precautions. Next, and this is the idea, it's the minimum standard work to prevent the exposure to pathogenic agents. Next. And it involves education, personal protective equipment, hand washing, and employing safe work practices. Sounds like COVID, doesn't it? And it requires the individual to assume the material or the patient or the neighbor to be infectious and to act accordingly. Next. So we need to use universal precautions when prescribing opioids. Next. And I'm going to strongly recommend the ACIP guidelines for responsible, safe, and effective prescribing of opioids. Next. These were written in 2017, and as a summary, they had, you needed a comprehensive assessment and documentation, screening for opioid abuse, utilization of prescription monitoring programs, PDMPs, utilization of urine drug testing, establishment of an appropriate diagnosis, recognizing that low back pain is not a diagnosis, abdominal pain is not a diagnosis. These are symptoms, and you need to understand why they have those problems. Consider appropriate imaging, also recognizing that MRIs can show pathology in otherwise asymptomatic patients. Establish a medical necessity, stratify patients based on risk, establish treatment goals, and obtain an opioid agreement. Next. So when are opioids indicated? When pain is moderate to severe. Next. When the pain has significant impact on function. When pain has a significant impact on quality of life, when non-opioid pharmacotherapy has been tried and failed, when the patient agrees to have opioid use closely monitored. And so my last thought here is few things a doctor does are more important than relieving pain. Pain is soul destroying. No patient should have to endure intense pain unnecessarily. The quality of mercy is essential to the practice of medicine. Here, of all places, it should not be strained. Next. And next. Okay, and thank you very much. This is my email address. Anyone who would like the lecture, I'm happy to do that. And anyone who wants to have a discussion further, I'd also be very open to that. Peter?
Prescott with one T at the end. That's an inside joke. I sometimes have misspelled her name. I don't know why I have two T's at the end of her name. On some of in my phone, it still says two T's. But at any rate, I have to fix that. So Andrea, one of the areas that I kind of find, tough, and first of all, thank you for a wonderful review of kind of the facts. I think some of us get fed a line from the media or from insurance companies or from regulators, and it's important to stop and say, yeah, let's review the facts. Having said that, there are certainly risks of opioid therapy. There are certainly complications related to opioid therapy that may not be related to death, but in terms of quality of life and decrease in ability to engage, et cetera, there are problems. One of the big problems that I've seen, I really haven't seen a solution yet, is that I, as a physician, have always prescribed opioids. I've prescribed more at an earlier period in my life and then waned a little bit. I've never said no. The problem I have is I want to replace it with things like a peripheral nerve stimulator, or I want to replace it with an RF ablation, or I want to do a spinal cord stimulator. And the regulators, or sometimes the same people saying don't prescribe opioids, are saying, well, you can't do any kind of procedures because of cost. And that therapeutic nihilism has just been so frustrating to me. I'm looking forward to your thoughts on that.
Absolutely. I think that and one of the things I've been fascinated by over the years is watching people decrease opioids on their own as their pain gets under control. It is, in my practice, has been the rule rather than the exception. And so I think the patients, if you can get them to buy in on it, the problem I see is that when they're being taken off opioids and then offered a procedure, as opposed to getting them pain relief and then having them wean down the medicine. I think we've been doing it a little bit backwards, but absolutely the insurance companies are driving me nuts to the point that I'm ready to just start doing a cash only practice. I can do these procedures so cheaply for patients if I didn't have to do billing, if I didn't have to do prior authorizations, if I didn't have to battle with the insurance company. Come in, pay a little bit of cash, do prolotherapy, do even the peripheral nerve stimulators. We could cryo, hydrodissection of a nerve entrapment, even an epidural steroid. There are so many people who get good relief from that. Our basis cost is relatively small if we didn't have this huge overhead. So I really have gotten to the point where I'm about to pull the trigger and say, fine, just pay me X and I will do what's necessary to get you better. Maybe it's a pipe dream. I don't know. Not the right time to do it, but that would be my. In the meanwhile, all we can do is fight the insurance companies, explain to the patient that it is their insurance. They chose that insurance. They need to do the appeal because they are paying the premium. They need to contact the state insurance agent, the state of Florida, or the state insurance commission. If an insurance company is practicing in bad faith, they need to be the ones to take responsibility and do the battles. It's their insurance company, they're paying the premiums. I'm a supplicant begging from the insurance company to pay. And I keep trying to explain to the patient, the insurance companies are not in the business of paying claims. Otherwise, they wouldn't be able to build these big buildings with their name on it. They are in the business of denying claims. And when you look at it that way, then it sort of makes some perverse sense.
Yeah. Well, I wish we could talk for hours and hours about this, as I've always enjoyed our conversations together, and we will have you back again and hopefully in person. But thank you for being our inaugural external lecturer on an important topic such as this. You couldn't imagine a better expert for us. So thank you very much.
Thank you for the invitation. I greatly appreciate it. All right, on to the next lecture.
That's right. So with that, Dr. Truscott did mention the idea of prolotherapy, and what a better segue than to have our own Dr. Mayo Friedlis, who's one of the world's experts in regenerative medicine and pain medicine. Dr. Friedlis is actually 107 years old, but has been doing his own regenerative medicine for himself. That's why he looks like he's 35. But with that, Dr. Friedlis, I'm going to turn the podium over to you, and if you could teach us all a little bit about regenerative medicine and our practice and what you think we should be doing.
Yeah, Peter asked me to put together a little primer. Thank you, Peter, for the invitation. A little primer on regenerative medicine. And I understand we have some new physicians in the NSPC fold, and I've been at this for 30 years or so, so happy to share some things, give some people some things to talk about. And I understand I'm talking to interventional pain physicians. I'm an interventional pain physician, so I get the mentality that is interventional pain. The mentality of regenerative medicine is a subtly different thing. I'm going to try to explain that to you, and hopefully you see some value in it. Love to see some of you pick up regenerative medicine. I'm here to mentor you. I'm here to help you get started, help you get into this. Let's see if I can advance. Okay. Okay, I operate with 3 other physicians at Stem Cell Arts. That's the National Spine and Pain sort of higher level regenerative medicine practice, which we started a number of years ago. And it basically looks at regenerative medicine at a much higher level than just having a tabletop spinner and doing some PRP. That said, I think all of you are capable of operating at a higher level than just operating a tabletop spinner. So let's dive in and see what regenerative medicine really is. So from a standpoint of interventional pain, it's an innovative new option. Where does it come? Well, we begin when we see somebody with a pain problem. We talk about pharmacologic treatments. We talk about non-surgical options like physical therapy, chiropractic, dry needling, blah blah blah. And then we jump to interventional pain options to control pain, and we all know they're extremely effective. And we do good work and we fix a lot of people, but some people we try and fix and they don't get fixed. And it's a temporary thing only, and we're only covering up symptoms for a too short period of time. And some of the problems are surgical in nature, for instance, a torn rotator cuff or a herniated disc or a torn tendon in the Achilles. So we tend to send them right to the surgeons. And what I'm going to suggest to you is that regenerative injections is missing from your protocol. It should be right after you've tried interventional pain protocols and treatments and have failed that option. Don't go directly to surgery, go to regenerative treatment options. They can actually repair problems and they can actually help people in a very definitive fashion. Let's see. So what is regenerative medicine? Well, it's an orthopedic surgery and pain treatment alternative. So who uses it? People who are headed for orthopedic surgery and people who've tried interventional pain treatments and need something different. It should be called interventional orthopedics because this is what we do. Just like, when we put a stent in the heart, it's interventional cardiology. It's not orthopedic. It's not cardiothoracic surgeons doing this. It's cardiologists doing this. And who's doing these very fancy techniques to repair an ACL tendon interventionally? It's not orthopedists. It's interventional pain physicians doing regenerative medicine, otherwise called interventional orthopedics. What do we use? We use orthobiologics, biologic structures that can do orthopedic fixation, orthopedic repair, and fix orthopedic problem. The sweet spot of interventional orthopedics is just before surgery. People want to try it before surgery because they don't really want surgery. You may be best buddies with the surgeon, but guess what? They'd rather not have surgery. They'd rather be treated without surgery. I mean, it's what interventional pain is all about, right? It's treating people without surgery. So this just gives you another option to treat people before sending them to the surgeon. Having said that, it needs a different approach. As pain medicine physicians, what do we think of? We talk about treating pain generators, right? We always are thinking, okay, what's creating that patient's pain? Let's put a needle in it. Let's turn it off. And that's perfectly legitimate. Hey, it works. I'm an interventional pain physician, I know. If you think about doing regenerative physician, being a regenerative physician though, it's a different mentality. It's not about what's the pain generator. You want to know why the person hurts, yes, but you want to think about how can I fix that problem? Not that problem that's making the pain, but how can you fix the cause of the pain? And often they're different. Often it's a bigger picture than just a facet. And I'll give you some examples as we go on about how fixing the cause of the problem is different from trying to hit the pain generator. Okay, so regenerative medicine is one of the next iterations of interventional pain. We have a lot going on in our specialty right now, a lot of exciting things where we're doing more and more interventionally related projects, like foraminotomies, like mild procedures, like much more and more sophisticated spinal cord stim and peripheral stim, and much more sophisticated ways of intervening in the human body. We're doing fusions of the lumbar spine, fusions of the SI joints. This is interventional orthopedics. It's not, it's not just fixing, when we do these kinds of things, we're not just fixing pain, we're actually fixing the problem. We're fixing what's wrong. So it's a big, and regenerative medicine is very much like that. It's talking about fixing the problem, the cause, not just addressing pain. So this is just one of a number of new things that we're doing in interventional pain. So how do our tissues heal? We talk about healing tissues. How do they heal? I don't know that I knew before I studied up on it and before I was taught. So I'm going to go over what is the healing cascade in our bodies naturally, okay? So if we're injured, what happens is platelets come first and they form a clot in the tissue. And we all think of a clot as, oh, that's the way to stop the blood. It coagulates the blood and you have thrombin and you have all these things and platelets and you get a clot. Well, platelets do a lot more than that. They release growth factors when they're activated. And those growth factors are signaling proteins which attract special cells that your body has just sitting around waiting to help you. So those cells are like macrophages, fibroblasts, stem cells, other kind of regenerative tissues, and they migrate to the area. And all this migration of cells causes inflammation. That's what inflammation is. It's an attraction by your body of cells to help it heal. If we get a proper inflammatory response, and this is important, then we get the beginnings of tissue regeneration, which, if allowed to continue, leads to tissue remodeling and complete healing of the injured part. So if you have a busted ligament, it's going to bleed. It's going to get some blood supply in there, dumping its growth factors. It's going to get some stem cells migrating in. It's going to grow new ligament. You're going to repair your ligament. Beautiful, right? So here's the thing. If the healing process doesn't make it the first time, it only has one chance to make it, and then it's over. It's over. You never restart healing. Once you tear that tendon, it's either going to heal right away, according to the natural approach. And by the way, if you're taking a bunch of Motrin, hang on, why did I go back? I jumped ahead. Can I go back, please? Yeah, okay. So if it doesn't happen the first time, it's never going to happen. Regenerative therapies, by dumping growth factors into the tissue by way of platelets, by way of growth factors, by way of prolotherapy, these can all throw growth factors into the tissues and restart that natural healing process and help your body go on and heal that part. You know, we're all about immediate gratification, and one of the worst things you can do after an acute injury is grab the Motrin or the Advil, because remember we talked about that inflammatory cycle. If you don't inflame, you'll never heal. So all this use of anti-inflammatories likely is creating chronic injuries for us all. So keep that in mind if one of you or your loved ones has an acute injury. That rice stuff, that's not it, okay? That doesn't apply anymore to acute injuries. People who understand healing understand that. You know, you don't put ice on it to quell the inflammation. You let it inflame, you let it heal. You take painkillers, opioids if you have to, but you don't take Advil. Next slide. So let's talk about some of the orthobiologics that are out there that you can use. Well, you can use platelets. And if we take blood from you and we concentrate the platelets, we have what's called platelet-rich plasma. And there's a lot of bedside centrifuges that can do this, and you can buy kits and you can do this. And by concentrating these platelets to 4, 5, 6, 7 times, we can create very powerful mixes of growth factors. And when we inject them into torn tissues or injured tissues, we can help the body build new tissue. It's great for mild arthritis. It's great for small tendon and ligament tears. Next slide. So if we take those same growth factors, if we take those same platelets and we extract the growth factors from them, and we can do that by letting the sample clot And when you clot it, what happens is the platelets get activated and they release their growth factors. We have a process in our laboratory. We have our own laboratory in our office. We're part of a company called Regenix that gives us some protocols to use. I'm not here to talk about that. That's a separate thing. Anybody wants to know, you can call me. But we can concentrate growth factors after extracting them from platelets. You can do this yourself with something called a platelet releaseate, in which you just let the sample basically clot and then respin it, and then that supernatant has growth factors in it. So based on our extensive experience, these growth factors are really, really useful, different from platelet-rich plasma. You can use these platelet growth factors around nerves to help them heal. And helping them heal is critical, because sometimes I see lots of people and you know, with radiculopathies, and I'll treat them with 3 epidurals with corticosteroid first because A, it works, and B, it's cheap because their insurance will pay for it. But if that doesn't work and they've got a herniated disc and they're otherwise looking at a surgical repair, I will inject those with those same people at the same levels. I will inject with platelet growth factors. And those platelet growth factors can help that nerve and that disc to heal. Now, we're not talking magic here. It doesn't push the disc back in and plump up the disc, but it makes people stop hurting and it makes the discs shrink a little bit. And if you do, in a lot of the cases, it does shrink back in, but that's not something we promise. So we treat this, we use these extensively to treat epidural for radiculopathies and for disc injuries like annular tears, like disc bulges and herniations. So we can use these growth factors to help people who've had surgery and their nerve still hurts. And you've tried an epidural or 2 and it has no effect. These platelet growth factors can help that bruised nerve go on and heal. So it's pretty cool stuff. We use them peripherally at carpal tunnel, radial nerve impairments. You know, lots of times you can't get this lateral epicondylitis good, even with PRP, and it turns out it's a radial nerve entrapment here. You could hydrodissect that radial nerve with growth factors, with the platelet growth factors, and it will heal that nerve and fix the problem. You can use it for ulnar neuropathies. You can use it for any kind of neuropathy peripherally if you hydrodissect with these growth factors under ultrasound. Next slide. One more slide, please. Okay, so stem cells. Everybody talks about stem cells. You can isolate stem cells from your bone marrow. These are called mesenchymal stem cells. That's the best way to get your stem cells. The FDA has not licensed fat-based stem cells, adipose stem cells. I know you'll find articles on it. You'll find people talking about doing it, but the FDA has not licensed that, and you are going against the law to use adipose-based stem cells. But I encourage you to use mesenchymal stem cells from the bone marrow. They're easy to harvest. Anybody can, I'm happy to teach anybody to do it. I wrote a book chapter on this. I can refer you to it. It's easy to harvest stem cells and pretty painlessly if you do it right. And that's the best way to use stem cells. It's the way your body does it. When your body needs to heal a joint or a tendon or a ligament, it does not get those stem cells from fat. It gets them from your bone marrow. We know this from the research. So this research, I mean, these stem cells are quite useful. And when we do a bone marrow aspirate and then concentrate that down, we can come up with quite a number of stem cells which can help you heal or help your patient heal. So next slide. Regenerative medicine can literally be used all over the body. We have this chart in our office, and it just reminds patients, you know, they come in for their back, but they got a knee problem. And, oh, you guys treat knees? Yes, we treat knees. You treat shoulders? Yes, we treat shoulders. So we treat basically the whole body when we do regenerative medicine. And the spine is a lot of what we do, but we also treat shoulders and hips and knees and ankles. Any place there's a musculoskeletal injury of a ligament, a tendon, a muscle. Even a non-union of bone can be treated with platelets and with stem cells. So next slide. And caution, not all PRP is equal, not all stem cells are equal, and stem cells don't cure everything. These are regenerative treatments. They can help the body to heal, but they're not magic. You know, it's not like these things cure everything. You have to pick your cases properly. You have to make sure the patient is fully educated that this is going to help them heal and will improve their situation, often permanently, but we don't promise cures. And not everybody is a candidate. Some things should go rightfully to the surgeon, and we have to understand that. So these products out there, amniotic stem cell products, they're fake. They do not have any stem cells in them. The FDA is cracking down on them. Don't be caught using them. You can use amniotic products as a construct, and it's basically a fibrous construct that you can put in a gap in a tissue, and then put some platelets on it or put some stem cells on it. It's to fill in a missing piece of tissue, like in a rotator cuff, where you have a gap in the tendon. You can use an amniotic construct in that, but it's not a stem cell. Don't be calling it stem cells. Don't tell patients they're stem cells. That's misadvertising. It's false advertising. It's misrepresentation, and you can get into trouble for that. And so that's that. So be careful how, you know, what we're talking about. We're talking about real platelets, real stem cells from the patient's own body, put back in the next day. So thank you. Next slide. Oh, I got my slides back. Here we go. Let's go. Okay, we got it. So what do we do with this picture? What do we do with this patient, I should say? We don't operate on MRIs, do we? We treat patients. So here's a patient with obviously some discogenic issues. And here's the next slide. You can see we got some other issues going on here. And let's just talk about what this is. And let's talk about how we would treat it interventionally and how we would treat it regeneratively. And I want to start to show you what the differences are and how they might differ. So it's a 56-year-old man with lower back pain and an L4 radiculopathy without weakness. The findings on the MRI, what did we see? Well, we saw facet disease, we saw degenerative disc disease, we saw a herniated disc, we saw nerve impingement. Anybody catch the muscle atrophy? Go back one slide, please. Anybody see this stuff in here? This looks like rib steak, like really expensive stuff because it's full of fat, right? It's supposed to look like this over here, or even better. It's not supposed to have all this fatty atrophy in here. These are your main structural muscles, the multifidi, that support your spine. Why are they failing? They're failing because they're not being used properly, because we have a painful segment here. So if you go in and fix this segment with, let's say you want to help this person's problem interventionally, what are you going to do? Well, you probably do an epidural and see if you can cut out their pain. If that doesn't work, you do, I mean, a series of them. Maybe you'd do some kind of disc procedure, an RF procedure, or maybe you take out some disc material and try and help them. Maybe you'd send them to the surgeon. Maybe you decide that the pain wasn't really the nerve so much, it was the facet joint, and you'd inject the facet joint, okay? And those are and maybe you'd radiofrequency the facet joint if it wasn't a long-term prospect. And maybe you put a spinal cord stimulator in if they still had pain and they didn't want to go to the surgeon. Those are all the interventional treatments. So let's talk about the regenerative treatments. Remember, regenerative treatments, we talk about actually fixing problems. So what's the problem here? Is it a pinched nerve, or is it a failing segment? Is it a failing disc segment with a collapse of the disc and a destabilization of that segment, too much pressure on the facet joint, and some muscles that are atrophic here and not doing their jobs? So to treat this regeneratively is a compound treatment. We're going to do an epidural with platelet growth factors. We're going to hit this facet joint, and in fact, both sides, and the one above and the one below, both sides, with high density facets designed to treat arthritic joints. When I say high density, I'm talking 10, 12, 14 times concentrate. So some really powerful platelets. And then I'm going to take some platelet poor plasma or some prolotherapy. I'm going to inject these muscles, and it's going to encourage the growth of those muscles along with a rehab program. By the way, a core exercise program won't do anything for this, but it will help if you've injected here with platelet poor plasma or prolotherapy. It's going to help regenerate those muscles. We've seen it. Now, if that all fails, we can inject this disc with either platelets, 14 times concentrate, or we can inject with stem cells, or a combination of both, a little platelets, a little stem cells. And that can help boost that tissue inside the disc. It's not going to build a new disc. It's not going to plump that disc up like it was new, but it will treat discogenic pain very nicely to the level of about 75%. Platelets and stem cells both work. So those are the kind of different approaches we would use using regenerative versus interventional pain. So, and often patients will want to do the interventional pain route first. And then when the next step is them having either a surgical procedure or getting an implant of a stimulator, they'll jump all over regenerative treatments. So the sweet spot is when you've finished interventional treatments and then pick it up with regenerative treatments. Now, some people will come in and they've done their reading, they've done the research, don't want corticosteroids, they want platelets, they want stem cells, they want to try and fix what's wrong. So that's a different kind of patient, and they're all over it. So no problem at all. So again, it's different from looking for pain generators. We're trying to treat the whole segment, above it, below it, etc. Next slide, please. And just to put a finer pencil on it, a finer point on the pencil, this is a slide of ligaments of your spine. So do any of you pay attention to ligaments? I doubt it. I never did before I learned about regenerative medicine and how important ligaments were. They're important for two reasons. Number one, they're pain generators. They create what are called sclerotomes, and I can't tell you how many people we've fixed treating their ligaments when some other pain person has tried to treat their facets and their SI joints by injecting intra-articularly or doing epidurals, and you treat all their ligaments and they're fixed because these ligaments create pain, and it refers pain in much the same way nerves do. We call it a pseudoradiculopathy. But there's a second reason we treat them. We treat them to stabilize the segment. So on that previous patient, we had an L4-5 problem. We had an L5S1, 4-5 and 5-1 problem. So the 4-5 one was the one where he had, it was 3-4, I think, that he had the herniated disc. And so we would treat this whole segment. We would treat the facet capsule at the level above, 3-4, 4-5, on the other side as well. We would treat the intratransverse process ligaments. We would treat the disc if we had to. We treat the supraspinous, intraspinous ligaments. If the patient had spinal stenosis, these cases we're sending to mild, that we take a couple bites out of their ligaments, right? Well, how about this? If you inject the ligamentum flavum with PRP, guess what happens to that overgrown, doubled up ligament? It gets tighter, and it gets thinner, and it gets stronger, and it basically shrinks back. So you can do a lot of the same things with regenerative tools if you know how to do them. And injecting the ligamentum flavum is simple. It's just like an intralaminar epidural. You just don't go all the way in. And you can use platelets to do that. So next slide. So I think we went over this. So for discogenic pain, we can use the platelet lysate or releasate. We can use PRP to the superior, adjacent, inferior structures, including facet joints, supraspinous, intraspinous ligaments, sacroiliac joints, iliolumbar ligaments, all to try and stabilize that segment that has the failed disc. So we're talking about what caused it. Well, the failed disc caused all these problems. So how can we bolster up that disc? So we talked about injecting for facet pain, injecting the joints with high dose platelets to try and treat the arthritic component in that facet joint. And 2 or 3 times, 2 or 3 repetitions, and that facet joint that was not responding to RF or not responding to corticosteroids can be pain-free. Not forever. You haven't cured the arthritis, but we're talking about a repeat treatment maybe in a year, 2 years, 3 years, not in 6 months. And you know, I know a lot of you don't know how to examine for sacroiliac instability, but it exists, and if you have sacroiliac instability, it causes disc instability and segmental instability above it. So it's important to address as part of your treatment. Always address the sacroiliac joints for stability. Next slide. So this is just you can go out, have a look at this later if you want. It just shows you for each structure, there's different kinds of orthobiologics that can help, and which is the best one to use for that. Case 2 is about a knee, and you know, again, you may think that if you're going to treat a knee with a corticosteroid, you just inject the corticosteroid and treat their pain, right? And a lot of you are tempted, I'm sure, if you use PRP, oh, just inject it like a corticosteroid. But let me remind you, you're not treating pain if you're using an orthobiologic, you're treating function and you're treating causation. So what makes a joint arthritic? Well, it breaks down the cartilage for sure, but there's also instability that occurs when the cartilage shrinks. The ligaments get lax. So part of treating a knee arthritis is to treat their medial and lateral collateral ligaments, their joint capsule, the attachment site of their meniscus, along with the, you know, the little ligaments that attach the meniscus to the tibia. Those are all important to treat, and they can all be treated with platelets, but you have to take the time to treat them. So you don't just throw it in like a cortisone treatment, because you're not chasing pain, you're chasing function, and it's more difficult, it's more involved, but it's more rewarding because it can actually last. And you can, you know, you can actually treat ACL tears like this very elegantly without sending them to the surgeon for that horrible operation of ACL repair that leads to arthritis 10 years later. So you can actually fix ACLs even if they're totally torn by injecting the proximal and distal piece, and there's a technique for this, with stem cells, and you can get it to grow together. So next slide. So I'll leave you with this. This is just an example of one of the treatments we might do on a knee. Here's an arthritic knee, and we're treating, in this case, the patellofemoral space. You can see right here on the MRI, there's a bone marrow edema here in the patella. And I know we're all taught to ignore these, but it turns out they're important. And the research shows that this cartilage here on the surface of the patella really can't heal unless this is healed. So now what we do is we put a special needle, a trocar, right into this area right here and inject stem cells there. We inject stem cells along the cartilage surface here in the patellofemoral joint and make sure they layer out there and give them time to attach. And then we also inject on the trochlea here, the opposing side. There was a little bone marrow edema here, so we're running a catheter in there too. So this is how we would do a stem cell treatment on a knee to actually get an orthobiologic in there properly to do the work it's meant to do. So that's the story. I could talk all day on this stuff, obviously, and you can see I love what I do, and happy to take questions by email. It's mfriedlis@treatingpain.com. Happy to help anybody out who wants to get into regenerative medicine, and you know, happy to get you started, talk you through it. What do you need to do? What training do you need? And those kinds of things. So. And that's thanks very much, Peter. I appreciate it, and hope everybody got a little taste of regenerative medicine.
Mayo, we deeply appreciate you participating. While we're talking for a moment, Dr. Vallejo is going to be a few minutes late. So Dr. Sejan, if you're on, if you could join us, log in. And Stephanie, if you could move the slides forward to Dr. Sejan's presentation. But so while we're doing that, Mayo, you know, one of the things that, I mean, this is really such a cool time to be involved in medicine and in pain medicine and our whole field. And really, all the paradigms that we think about in healthcare and pain have just been turned on their head. First of all, you know, spinal cord stimulation should be a last ditch effort. We only put in a stimulator if everything else fails. Well, now we've learned that this works much better than many types of surgeries. And so that's been flipped on its head. We've started in the last 10 years, I would say, to really become facile with ultrasound. And that's opened up a whole new world that we've been able to leverage our field of regenerative medicine into and really be very specific on our placements. But it's asking us to rethink some things. It's asking us to rethink, you know, well, we've been injecting epidural steroids for all these years, and you're telling me right now that everything I've been doing for the last 30, let's say 60 years in our field, since the 1960s, really, we were injecting epidural steroids. That's all been somewhat flawed because we're decreasing inflammation, but that's not what we want to do. We want inflammation to go in and fix some of these problems. So there's this irony that I see going on. So any comments about that?
Yeah, I'm glad you brought that up because I want to dispel that misunderstanding. Nerves heal by decreasing their inflammation. So when we put those growth factors in, they don't create inflammation around a nerve. When we put platelets inside a ligament, that's recreating inflammation. So musculoskeletal tissue, ligaments, tendons, those all heal with inflammatory response. That's important to recreate, to get them to heal. But nerve structures, that's different. They don't go through an inflammatory phase to heal. They go through a de-inflammation phase to heal. So the platelet growth factors actually take the inflammation out of the nerve, just like the corticosteroids. So corticosteroids, I always treat first with corticosteroids when I'm dealing with a nerve. I don't like to treat first if I'm dealing with a osteoarthritic knee or a rotator cuff problem. I like to treat regenerative first. I'll do one cortisone shot, but I don't like the possible degradative effects of them. So, but around nerves, 100% cortisone first. It works wonderful.
Well, Mayo, you're such a wealth of information, and NSPC is so fortunate to have you, and thank you for an excellent primer. I'm going to torture you again for when we do our Business of Pain conference this October to dive a little bit more in depth into some of these areas, technically, as well as the science of what we're doing there, to get people up to a point where they can actually consider this as part of their practices. So, but thank you very much. Now I'm going to turn it over to Dr. Sejan. I'm very pleased to have Dr. Sejan here. He and I have been friends for many, many years. We lost contact, and when Prospera joined back up with NSPC and there was the merger, I got to see him again, and I'm so thrilled with his progress and success over the decades. Dr. Sejan has done something that I've only talked about since I left Hopkins, which was to create a real fellowship for pain physicians. And on the surface, you think, okay, you're not an academic institution, but when you dive into it and you look at the expertise and the flow through of a busy practitioner by Dr. you can't really imagine a better training ground than what Dr. Sejan has created. So I've asked him to put together some thoughts for us, to talk to us a little bit about the fellowship. If anybody's interested in doing some training of the fellows, they can speak with him and maybe give us some thoughts about expanding it and overall what he thinks it should be. We went out of order. Dr. Vallejo's tied up with something, and I'm hoping he's going to be done when Dr. Sajan is done. But at this point, we're going to turn it to Dr. Sajan and talk about training and fellows. Dr. Sajan.
Hi, good afternoon, everybody, and thank you for giving me an opportunity to talk to you about one of the things that, we as physicians, as part of NSPC, we do a lot of things, and I think training fellows, training new physicians is one of the things that provides us the most satisfaction, because we are helping in furthering our group and having new doctors come in and get. I'm really happy. I'm really glad to be part of it. Next slide. Okay. Can we go to the next one? Can we go to the next slide? Yeah, thank you. So go one back. Yeah, so as far as the fellowship program is concerned, the fellowship at Prospera, we've had it for almost 12 to 15 years now. And initially it started with one fellow every year. And over the past few years, we have grown the fellowship to where we have between 2 and 4 fellows every year. As far as the background of these fellows are concerned, most of the fellows are either from anesthesia or physical medicine and rehabilitation, but we've had internal medicine doctors, we've had psychiatrists, we have neurologists, and we've also had actually a radiologist who had done a fellowship in interventional radiology but wanted to move into pain. So we've got a wide variety of physicians who've gone through our program and who are doing really very well now. So our fellowship is a one-year fellowship, and because we are a non-accredited fellowship, we have a little flexibility about when the fellows start. So usually most of the fellows start in the June, July, August timeframe, but we've had fellows who are off cycle and start in December, January, depending upon when they complete their residency. Can I have the next slide? So our fellowship is predominantly focused on interventions. Can we go one slide back? Sorry. Yes. And the big point about our fellowship is the number of procedures that the fellow gets to do through the year. I would say that almost 80 to 90% of our fellows have at least done 750 procedures or more during the course of the year, which is a pretty big number when you come to look at it, and not many other fellowships can boast of such big numbers. I would say that the way that our schedule is built is that each fellow spends about 50 to 60% of their time in the procedure suite with different doctors, and the remaining 40 to 50% of the time is spent in the office seeing patients and learning from the physicians. Each of our fellow usually rotates between 3 to 5 physician proctors, and this is actually very useful for the fellows because each of us have different techniques in doing the same procedure. We examine patients a little differently, so the physician or the fellow gets a chance to go through and see how different physicians practice, and they can pick up what they feel is best for their future practice. Next slide, please. So as far as the fellowship is concerned, one of the big things about our fellowship is that we have a didactic series, and we have the didactics for usually about 7 to 8 months of the year. We do this once a week, and most of the time it is done during a weekday during lunchtime, so that it does not come in the way of any patient care. And also it gives an opportunity for the rest of the physicians and the PAs and nurse practitioners and anybody else who would like to attend the lecture to be part of that. The way that we have been doing it so far is that all the physicians in Florida would give one lecture, and the fellows would do a journal club. And next slide, please. So like I said, the lectures are usually for an hour. It's done at lunch. It is open to all the providers. We send out invites to the physicians, PAs, nurse practitioners, and any of the office staff who may be interested in listening to any topic that interests them. We have been doing this on Skype so that we have physicians all over can participate. And the topics for the lectures have been chosen from established fellowship programs around the country. Now, this is not a fixed series. Depending upon the interest of the fellow or maybe the interest of the physician giving the lecture, we are always flexible and can add or subtract any of these lectures. The next one. As far as the fellowship training is concerned, the first 1 to 2 months is usually spent going through the basics, learning how the C-arm works, looking at the different angles with which we do these injections. And the remaining 8 to 10 months is pretty much intervention heavy. At the end of the fellowship, most of the fellows are able to take the American Board of Pain Medicine or the ACIP boards. And I would say that every single doctor who has gone through our fellowship has passed these board exams in the first attempt itself. The one thing that they cannot do is the ABMS board because our fellowship is a non-accredited fellowship. None of our fellows have ever had any issues with credentialing with either hospital systems or with insurances, and they have been able to practice as a full-fledged pain physician once they have completed our fellowship. The only area which they might have a problem with is if they decide to go into an academic practice, then you most likely need a ACGME accredited fellowship. But otherwise, in private practice in every single state in the US, we've not had any problem with accreditation or credentialing with any insurance. Next slide. Now, apart from the training that these fellows get, what are the benefits that we as a practice derives from these fellows? So one is obviously that they help with coverage. And many of our offices in Florida, and I'm sure it's the same in other places in NSPC, there is only one physician in an office with 1 or 2 PAs or nurse practitioners. So when the physician takes time off or if there is an emergency, these fellows, the fellows help with coverage. And this helps with keeping the offices open and the patients to be seen, because otherwise we would have to close that office. They help with coverage when when somebody is on PTO. And more importantly, they keep us physicians up to date. I'm sure that when we have a very busy practice, sometimes we do not get time, or we are, I would say, maybe lazy enough to keep in touch with the new journals and what's happening out there. But when you have a fellow who is inquisitive and he's asking, or he or she is asking you questions, you would also try to keep up to date. So I think that helps us as physicians. I must say that the first 3 to 4 months during the fellowship cycle is a little difficult for us physicians, because it may slow us down a little bit. We have to take a little bit extra time to explain things to the fellows. But once the first 2 to 3 months or 3 to 4 months are done, then actually it is a joy. It's a pleasure actually to have someone with you most of the time, and for us to impart our knowledge and our training with them. So majority of, or I would say almost all the physicians who have trained fellows in Florida have actually enjoyed that experience. The next slide, please. As far as the fellows at the end of fellowship, I would say that about 50% of our fellows join our practice as faculty, as physicians. In Florida, I would say that there is at least 8 to 10 of us who have gone through the fellowship, who are now practicing and practicing very successfully. The advantage of have a fellow joining our practice is because they've been with us for the last 1 year, they know all the positives and negatives of the practice, and we do not have to really spend a lot of time explaining the benefits of staying in our practice. And with our practice now expanding to multiple states, if a fellow is interested in moving to a different state and practicing there because of family reasons or for anything else, that is an opportunity that they have. They have multiple choices, and we have had fellows in the past who have moved on to other practices in Prospera and are doing well there. And like I said, I mean, the biggest plus point of being part of the fellowship is that it helps us to give back to our pain physician community. We do a lot of things for ourselves, we do a lot of things to help our patients, but this part of our practice is actually giving back. I mean, giving back to this community, which has given us a lot and given us a good career. The next slide, please. And now, I mean, with the merger of NSPC and Prospera, I mean, it goes without saying that we have a significantly large pool of who's who in the pain industry. I mean, we have all the doctors who are publishers and who I mean, we actually learn from them. So it would be a big advantage to have people like Dr. Stats and others give lectures or spend some time with these fellows, and I think that will go a long way in not just helping the fellows, but also in making our fellowship one of the most sought after in the country. We have a big research department with NSPC, and we did have fellows take part in some of the clinical research that we at Prospera were doing, but now with the increased research personnel that we have, that would that would be possibly like the icing of the cake for the fellowship. Our goal is to be the best interventional pain program in the country, and I think we are slowly getting there. Most of the other interventional practices, they do a lot of inpatient pain, but they're not very interventional heavy. So I think our practice, our biggest goal is to get good interventional, and not just interventional, but all-round physicians to graduate from our program. The way we get fellows is that usually we send out emails to all, so far we've been doing it to all anesthesia and physical medicine and rehab residencies, usually around July, August of every year, so that the final year residents know about our practice. And we also go for conferences where we talk about our fellowship, and that's usually how we get our fellows. With merging with NSPC, NSPC doctors have been doing very high acuity procedures, so that is now being added to our fellowship experience. Things like the zip fusion, mild, Vertiflex, things that were not very high on our list in the past. Now our new fellows are going to be exposed to that, so that is a good advantage of having a big practice like ours. The next slide. As far as this year is concerned, we have filled we've got 2 new fellows who've signed on in Florida. We have 1 more open position in South Florida that we are actively recruiting for. We've just recruited a fellow who is going to be starting in the Virginia, DC area, and Dr. Mangal is going to be the main proctor, but we've got other doctors who are also going to be training the fellow. Like I said, our goal is, I mean, obviously we would like to expand the fellowship. We may add a few more fellows depending upon the interest that we have from the other physicians. But more than the numbers, we like quality. I mean, we want to make sure that our fellowship program is the best in the area. And so if anyone is interested in being a proctor, in training a fellow, like I said, we are open to expanding the fellowship program. I would love to hear from you, and if you have any questions, please reach out to me, and I'll be more than happy to explain a little bit more about what it takes to be a proctor for our fellowship program. And that would be it.
Dr. Sajan, thank you. And thank you for your wonderful care and interest in taking care of our fellows. Like you pointed out, they really are our future. And why not train our own how they should be trained, as opposed to take someone who's only partially trained from a place with a good name, and then you have to train them again. So that's really great. You mentioned, as we start to expand our research, fortunately, we have, we're dovetailing your great work with the great work of Dr. Vallejo, and there's so much that we would want to talk about. I want to take it offline with you, Dr. Sajan, about the FIPP, the World Institute of Pain exam, and others, whether or not what we can do there. So, as you know, I'm now president of that organization, and so there may be some opportunities to improve the training and experience that people have. And I don't know if it's possible, but let's talk about that. We're going to wrap it up with Dr. Vallejo tonight. Dr. Vallejo is going to talk to us briefly about methodologic considerations in our private practice setting. Research isn't easy, but it's really gratifying. And Dr. Vallejo goes to work every day and stays there at 8:30 at night wearing a tie. I'm going to ask you to just kind of, briefly talk to us about research and what we should all be thinking about. We're a practice now of 11 states, 130 some odd sites, and 300 practitioners, 1.4 million office visits a year. Is it possible to do research on that?
Yes, it is. And first of all, I would like to congratulate Sajan in his amazing presentation. And if the position is still open in Florida, I'm moving there next week, so I may be able to apply for one of the fellowship positions. In the meantime, what I will try to mention to you is, why are we doing research in private practice? And I would say it has a lot to do with Dr. Sajan was mentioning earlier. One of our main goals as physicians is to learn. I think as physicians, our goal all life is to learn more and more about the science of the medicine. And I think because of this background, it's not surprised that many of us have this desire to continue doing research even after we have finished our training. Next one, please. So I joined National Spine and Pain Center a couple of years ago. And by the way, this is my conflict of interest. Next one, please. And from very early on, my main goal was to do research, clinical research, which is what I'm going to talk about today, but also basic science research. And everything comes, and I think you all are scientists in some ways. You are observing your patients, and when you are observing your patients, you are proposing what could be the diagnosis that is leading to this malady that your patient has. And as you do that, you are just simply applying the scientific method. You are coming with a diagnosis. You have a hypothesis of what could be going on with your patient, and then you propose different treatments in order to determine what are the results. So you make your own conclusions. So at the end of the day, we all are involved in this phase of the research, and this is a very fast growing industry. According to Forbes and Fortune, is one of the fastest growing industries right now around the world. Next one, please. Now, why do we do it? Once again, we do it because we want to learn, but we also want to be updated. One very good thing about doing research is that you're going to be listening about what is the newest thing that is coming into the field. You will be exposed, not only you, but also your patients, to novel therapies. They will be able to get treatments that otherwise will not be available for that. And you as physician will get recognition within the scientific community, and you will have a lot of different opportunities to interact with industry and also to provide value as a speaker or in the podium, where you're going to be advocating for these therapies that only you as a researcher will have access to. Next one, please. Now, what are the big challenges? One is the cost. Next one. Because right now, if I want to conduct a very large study, there is multiple aspects. Next one, please, that I should be looking into. One is, how am I going to be able to enroll in a timely fashion? How am I going to be able to bring this product from the concept all the way to the market? You know the numbers. If you have a pharmacological agent that you want to bring into the market, it will be 1.3 to 1.7 billion dollars, and the numbers are just going higher and higher. Next one. So as you think about all these challenges that you have, next one, you will see that one of the most crucial aspects is that you have to reduce the cost of that. And one of the challenges, next one, is that if you are trying as an innovator, you are bringing these alternatives or you are trying to bring them into the market, you're going to have a very big challenge if you try to get approval from a academic institution. Very often, just developing the protocol with these different institutions can take you a long time. You won't be able to do that. And as you get more and more data that are going to be requested in the study, more expenses that will be leading to that, one fundamental aspect is that you are able to recruit the patients in a timely fashion, but also is critical that you will be able to have a very good data collection. All these experiments that you are doing could be of no value at all if you don't have the right tools to integrate that and avoid deviations from the protocol. So what you need to have is a setting where you can recruit a lot of patients, and Peter just mentioned 1.4 million visits per year in our National Spine and Pain Centers integrated network. This is something amazing, and any company will be very excited to have access to these patients. So those are very critical aspects that we in National Spine and Pain Centers have access to, and that really will make a difference in terms of how can we create and generate this clinical data more efficiently. And obviously, many companies, pharmaceutical companies, device companies, are looking at this type of fast enrollment, high quality research in order to optimize the results that they can present to the FDA. Next one, please. So, as I mentioned earlier, one of the major problems is delayed enrollment. And if you go to an academic institution, it's going to be hard for you to enroll patients in a timely fashion. I remember back in the days for a couple of studies in spinal cord stimulation, like the benchmark study or for the SENSA trial, we in Millennium Pain Center, we were the fastest enroller or the higher enrolling in the two studies. And that's because we in private practice may have a better access to this patient population. And the patients, I can tell you from my experience, they are delighted to have this opportunity to be able to participate in studies and also have access to some of these studies that otherwise they will not be able to. So it is very important. Now, you as a practitioner, probably you are working all day long, and as you are doing that, you may be wondering when and how am I going to be able to do that? Next one, please. So one of the major opportunities that we have is that, different from academic institutions, we can go with external IRBs. Those IRBs can approve protocols in a very short, timely fashion. But we also have within the organization, and now with Dr. Sajan joining us, and again, I will be very happy to have this conversation off the line with him and Dr. Stats to try to see how do we increase this integration between the two groups to make it even larger. But we have right now within our institution, we have regulatory, legal, compliant expertise. We have clinical research coordinators that are certified and have been working in the field for many years. All these give us the right set for anybody that wants to get integrated into this research, that do not have to start from scratch as I had to do 20 years ago and learn so many requirements that are necessary within the clinical research. So that by doing that, you will have a whole set of team that is already knowing what is the best way for you to run a study, so you can focus in what you are really good at, taking care of your patients and making sure that these patients get the best possible relief. Next one, please. So if you want to start a research group, basically what you need an office, you need a space, you need a curriculum, you need an address, and then what you need is the support. And right now it is considered that just by doing one research, each study can bring around 100K to the clinic that you are working on. And again, right now we are conducting close to 12 different studies along national spine and pain centers, all the way from Florida with Dr. Mikovic, Dr. Sean Lee in New Jersey, here in Illinois. So we are trying to integrate all these abilities that we have in terms of the knowledge from compliance, from regulatory, for all the experience in terms of how to negotiate a budget, how to do a site initiation visit, how to make sure that you have all the different documentation ready. All these can be part of you if you are interested in becoming one of the researchers in our group. Next one, please. So again, one of the interesting aspects of this research, and it's perfectly complementary with what just Dr. Sajan mentioned, is that if you look at our core values, we want to improve the care of our patients. We want our patients to have the best ability. We also want to be advocates. We cannot go there and just in this day and age say, oh, you know what, my radio frequencies work fantastic. Well, you need to have data. So some of the things that we are doing, for example, right now, studies on spinal cord stimulation, where you just introduce the leads into the epidural space, but you don't have to connect that to an internal or implantable generator. Then we are running also studies for virgin back for patients with upper limb and neck with the use of spinal cord stimulation. We are also using SPR for the use of peripheral stimulation for the management of axial low back pain. We are using we are doing studies on cool radiofrequency for sacroiliac joint pain, for facet spondylosis. Treatments that unless you are within the research group, you will not be able to have access. And there is also studies on new forms of epidural steroids. So if these studies become positive, you will be able to advocate a therapy that will be FDA approved. So instead of just using off-label medications, we may be able to start using something approved for the FDA. So one of the main values of research is not only that all the potential personal benefits that you will have, all the benefits that you will provide to your patients, but also to the field in general, the ability to provide therapies and get those therapies well executed in research clinical trials that will end up providing the necessary data for different insurance companies and the government to pay for different types of therapies. So all those are the different roles that you can play within the research group that we have right now set at National Spine and Pain Centers. Next one, please. So what is the goal? The goal that we have is we want to make sure that if anybody has interest, and please, anybody reach out to me, I will be very interested in exploring the ability for different sites to become part of this large organization of research. But we want to make sure that you practice your medicine within a very secure environment where you can just involve your patients, provide them the help, while you have this peace of mind that nothing wrong is going to happen in terms of acquisition of valuable data. We have qualified, certified clinical research coordinator. We had a centralized process that handles all the way from the original proposal of the study to the approval of the study to the execution of the study. We have quality assurance and legal support for our studies. So by doing that, we can create a much larger organization, as we have been trying to do over the last year. And that can also help to escalate those findings or this knowledge that we are generating into different practices. And hopefully some of you that may be listening to this presentation will feel compelled about joining our research efforts. Next one. Okay, so again, thank you very much, and nice to see you again, Peter.
Great to see you, my friend. We actually ran a little bit over again tonight, so I apologize to everybody. If anybody does have some burning questions, please go ahead and chime in now. I guess, Stephanie, you'll send them to me. I don't actually see the other thing. I am desperately looking for our next few speakers. So if people have things that they want to talk about, please send me an email. I'm very interested in hearing your thoughts at pstots@treatingpain.com. Our next session will be on what's special about being a pain doctor, with another special invited guest. That will be Dr. Nalish Patel, is going to give us a special lecture with Dr. Kendall. We have some exciting new thoughts coming. I'm looking at doing something on radiation safety, and anybody's interested in talking about anything, please email me. If you think I'm missing a topic or need to change things, let me know. I know we're running a little bit longer, and I'll work on that, trying to shorten it down a little bit. Thank you, everybody. Happy New Year. Congratulations.
Bye-bye.
And we'll talk to you again in about a month.